introduction. Can you hear me?
Yes, we are able to hear you.
Perfect. Thank you very much. So I've been asked to cover this topic for which I have no particular conflicts of interest. My talk is going to be based essentially on two documents. The first is the error consensus paper from 2019 on the prevention, diagnosis, and treatment of CID infection. So this is really focusing on the topic that we're going to cover. This document is also available as an error key message, which you can download as an app from the error website for free. And also on a second paper, which has just come out, which is a consensus paper on optimal device implantation, which is also going to be coming out as an app. And I was honored to be able to chair this paper. There's also a lot of interesting material online available as supplementary materials, such as online videos and so forth. So just a bit of a background on device infections. The incidence varies across 0.6 to 3.4% at 1 year, depending on different prospective studies. There are different types of infection. There's an acute infection, which is following days or months after the device implantation, usually due to Staphylococcus aureus and due to the contamination of the pocket during the implantation. One can also have this as a secondary infection coming from the surface, say an infection of the knot that then progresses deeper and gets to the pocket. We also have late acute infection after a year, again, usually due to Staphylococcus aureus, which is usually hematogenous in spread from an external source. And finally, late chronic pocket infection, which takes years to develop, usually due to coagulase negative Staphylococcus aureus. And this again is due to contamination of the pocket during implantation, but because these germs grow very, very slowly, it's a somewhat latent infection and takes years to develop. So first of all, how do you diagnose device infection? Well, up to now, we've had different criteria. You may know the Duke criteria for endocarditis. There's also a revised version, which is the ESC criteria. And now, since this 2019 document, we have specific criteria for CID infection, not just endocarditis. And so infection actually can be diagnosed on clinical grounds, looking at the pocket, which shows swelling and oozing of pus, or also a pocket adhesions or threatened erosion. Or if you see the generator of the leads, well, then that's an infected device. And then there are also other criteria, two major criteria, one minor criteria, and so forth, which are somewhat similar to the Duke criteria. So this is an acute superficial stitch infection, which arose a few weeks after a box change. So it's really the knot that became infected, and this can actually be treated locally. It's not per se a device infection. This, on the other hand, is an acute infection of the pocket with a parallel discharge of Staphylococcus aureus, which is a definite device infection. These are chronic infections. They're a lot more difficult to diagnose because you may not have any redness, no tenderness whatsoever, just adhesions, which ultimately will cause a fistula to the surface, causing exteriorization of the device material. This is just an example of a patient in whom the diagnosis was quite difficult. An elderly lady who had several box changes, leads implanted over 25 years ago, and she comes because of some slight tenderness and then some very slight redness over the pocket area. But all the blood tests are completely normal. The question is, what do you do with this patient? She's elderly, she's got leads which have been in there since a quarter of a century. So do you treat this as an infection and extract all the whole device? Well, that's quite a major operation. And to be sure, we did a PET CT, and you can see that there's elimination, that there's hypercaptation around the box and also along the leads, which in fact helped us diagnose the infection in this patient. And we proceeded with an extraction of the material, which then grew Staphylococcus epidermidis. PET-CTs are becoming very useful for diagnosing, for confirming suspected infection, and also very useful for evaluating if there's any septic emboli in the organs. So based on the consensus document, if you have, there are several tests you have to run, of course, blood cultures, which may be positive or negative, clinical evaluation, and also echocardiography, notably transesophageal echocardiography to look out for vegetations. And also, as I just mentioned, PET-CT, which is becoming quite interesting and useful for diagnosing infection, especially off the box. It's somewhat less accurate for the leads. The microbiology, as I mentioned, usually Staphylococcus aureus for the acute infections and coagulase negative for the chronic infections. But in about a quarter of the cases, 30%, the cultures are actually negative simply because we've got very, very slow growing germs. There are a number of risk factors, the most important ones being hematoma and lead repositioning, which have a multifold increase in the risk of infection. And there's one protective factor, which is antibiotic prophylaxis, which reduces the risk of infection by 70%. And this is really mandatory according to a number of different randomized controlled trials. And you need absolutely to do this before a primary implantation or before a generator change. Moving on now to prevention, of course, the implantation should be done in a proper environment. It's preferable in an operating room. It can also be done in a cath lab, as long as this cath lab is properly ventilated with at least 15 air changes per hour, ideally more than 20. It's not necessary to have laminar flow. This is not proven to be of benefit. The patient needs to be properly prepared, use electric clippers rather than razors. So very simple tips, because razors, we know, tend to damage the skin and may increase the risk of infection. Give antibiotic prophylaxis, not too early that the antibiotics are washed out, but neither too late. So don't do this when the patient is on the table and you're incising the skin. The antibiotics should have been finished about half an hour beforehand so that they've had time to circulate and can effectively protect the patient. For the peri-procedural prevention, use preferably alcoholic chlorhexidine. You can also use povidone iodine as long as it's alcoholic, but there have been some randomized trials which have shown that chlorhexidine is actually superior, at least for catheter placement or for some surgical site infections. There have been no specific studies on device implantation, but extrapolating from the available evidence, we recommend rather alcoholic chlorhexidine. You should allow the antiseptic preparation to dry. Certainly don't wipe off the excess antiseptic. It needs time to kill off the germs. If you're using drapes, then use impregnated drapes rather than the non-impregnated ones, which actually increase the risk of infection. Use proper techniques. You can also use antibiotic envelopes in high-risk patients. I'll come back to that. There's no need, and there's actually no utility of instilling any antiseptic or antibiotics in the pocket. There's one randomized trial, the PADIT trial, which showed no utility of this, and this may maybe increase resistance. You can also rather use non-braided sutures for skin closure because they tend to cause less infections. This is based on expert judgment rather than any randomized trials, but several of us actually believe this quite strongly. So rather use non-braided sutures for closing the last layer. This is the antibiotic envelope, which has minocycline and rifampin, which the envelope is resorbed completely in 9 weeks and has been shown in the randomized RAPID trial, which included almost 7,000 patients, to significantly reduce the risk of major CID infection, albeit with a relatively high number of needed to treat of 200. And remember also that in this trial, these were really high-risk patients. So this is not a measure we would recommend as a routine measure, but only for patients who really are at high risk of infection, such as dialysis patients or box changes in high-risk patients. Post-procedural, don't use post-operative antibiotics. There's no evidence that this is useful. Apply a waterproof dressing for 2 to 10 days. The patient may shower during that time and thereafter should remove the dressing. We usually tell them not to take baths or to swim and so forth for the first month to allow the wound to heal properly. And of course, if you have hematoma, then this should really be treated conservatively as much as possible, unless it's very tense, very painful, there's sign of wound dehiscence, or if there's arm swelling. But in any case, resist puncturing and draining this percutaneously, because that's going to increase the risk of infection. So even very large hematomas like this, as much as possible, just let nature take its course and let it resorb without reintervening. You can also use pressure bandages, which can reduce for 24, 48 hours the risk of hematoma. Also, the perioperative management of antiplatelets and anticoagulants is really vital. So we no longer do heparin bridging. We really keep the patients on the oral anticoagulations, and if possible, we stop dual antiplatelet therapy if there are no high-risk features and if the PCI has been done after 1 to 6 months. Moving on now to management. If the patient has a superficial incisional infection, the treatment should be at least first-line conservative by cleaning up the wound, applying topical antibiotics and also systemic antibiotics for 7 to 10 days. Of course, if things get worse, then you need to move on and extract the device. If there's a definite CID infection, then you need to extract the device. That means the generator as well as the leads, and give antibiotics for 10 to 14 days if it's an isolated pocket infection. As soon as you have a systemic infection, then the antibiotic therapy needs to be between 4 to 6 weeks. Now, what about the indications for lead extractions? In fact, according to the Electra registry, which was a very large registry conducted in Europe with several thousand patients, infections were responsible for 53% of all the indications. And clear-cut indications include a definite CID infection, be it acute or chronic, isolated to the pocket or systemic, or just to the leads with lead endocarditis. You need to take the material out. Another indication is valvular endocarditis without any visualization of vegetations on the leads. But bear in mind that even with transesophageal echo, you don't see the entire course of the leads. You don't see what's going on in the innominate vein, for instance, or the superior vena cava up to a certain level. And you need to consider, that your device is also infected. More difficult indications are occult persistent gram-positive or gram-negative bacteremia, even though there's no other evidence of infection. Well, then you need to consider taking out the device with the leads. Contraindications are very large vegetations where there's concern that the very large vegetation may embolize to the pulmonary artery and cause hemodynamic collapse. Right to left shunts, of course, because of the risk of systemic emboli, and systemic leads for the same reason. There may be some instances where you do not wish to perform extraction because of a very elderly, very frail patient, or you may simply not have the possibility to do extraction. And if this patient has a chronic infection, such as this patient here, there is a possibility, this is actually not recommended anywhere, this is just my own personal, I would say, recommendation, would be to perform an incision at the level of the leads, to cut the leads in a potentially clean zone, to cap the leads here, and then to perform a second to extract the generator and the leads via the pocket. So you're pulling out the leads through here, and you're not allowing any contamination of this area, and hope that the leads, in fact, at this level are not infected. These really is, I would say, a bailout solution if lead extraction is not possible. I think I've only done this once. I'd like to conclude with this quotation that an ounce of prevention is worth a pound in cure. And I think that's especially true for device infections. Thank you very much for your attention.